Our next presenter is Dr. Khadija Mbeneka Elly. She's a budding gynecologist who's currently based in the Ministry of Defense as a senior civilian specialist at Isiolo Barracks. She has keen interest in gyne oncology. She will be doing a case report on adult type granulosa cell tumor. Karibu daktari.
Thank you very much for that introduction. So my name is Dr. Khadija Mbeneka Elly. I'm based in Isiolo, Meru. Sorry, I couldn't be present physically. I was very unwell, had a major surgery less than 10 days ago, recuperating from Nairobi. So my presentation is on adult type granulosa cell tumor. I hope I'm audible enough, by the way. It's on adult type granulosa cell tumor. So indolent, it can mimic a benign ovarian cyst. So this is a case report. We had a 54-year-old woman who came in, para 3+0, menopausal, but the menopause was not very clear because she just had almost exactly 12 months of amenorrhea. She had a gradual abdominal swelling over 1 to 2 years, growing slowly. And by the time she was presenting, it was corresponding to a 40-week gestation uterus. And she had bleeding after what she had presumed to be having menopause. So she had what we thought was a postmenopausal bleed. So imaging and laboratory findings, she had on CT scan a right ovarian cystic mass, large, no cyst wall projections, no lymphadenopathy or evidence of metastasis. There was some ascites present, and our CA125 was elevated at 60 units per liter. So I'll ask the gyne-onc enthusiast, what will be our RMI index? If you calculate, she's borderline, you don't know whether she's menopause or non-menopause. CA125, not so much. So the RMI index will definitely fall at intermediate risk for a carcinoma. So we went in, we did a laparotomy and intra-op. We found some ascites, which we took for cytology. Then we also found a well-encapsulated right adnexal mass, very large. It was around 40 by 40 centimeters. Omentum looked normal, no nodules, nothing. No palpable lymph nodes, both pelvic and parotid, and all abdominal organs were normal. We palpated the liver, the surface was smooth, spleen was smooth, and the peritoneum was also smooth. Had also some bulk uterus with intramural fibroids. So intra-op, we thought this looked largely benign. So we decided to do a USO, but because of the fibroids and the bleeding that was it menopausal or was it perimenopausal, we decided to do a TAH. But we removed one ovary, the affected one, the right adnexal. So these were the surgical images intra-op, and this is the surgical scar after the surgery. This also corresponded to another case that I did in 2023, same history, almost same age. I think she was 55, 54, 56. We did a USO, and for her it was a benign cystadenoma, and the images were almost the same. So the histology results came back 2 weeks later. Diagnosis was adult type granulosa cell tumor, stage 1A. The acidic fluid was negative for tumor, and the capsule was intact, no malignant cells in the attached fallopian tube, and no spread observed. So it was staged at stage 1A. So this is the histology report that was reported from PathCare. And we did a multidisciplinary discussion with a few of my mentors, both the MTRH and Toronto team. So the conclusion was that being an adult type granulosa cell tumor, no further surgery was required because we removed the disease. We had an optimal cytoreduction. And this tumor is almost always unilateral, almost always caught early stage. And if it's fully removed, then there's no need for additional surgery. For her, also no chemotherapy or radiation, but a 10-year follow-up because it's a tumor that can recur within a long period, like 10 years. Patient was to be appraised honestly and in writing that we didn't remove the other ovary, we didn't remove the omentum, and if she requested for additional surgery, then not to be denied. So we had this discussion with the patient, and she understood that the tumor is very indolent, and she declined any further surgery and agreed to clinical monitoring. So 6 months later, patient is doing very well. CT scan done 2 weeks ago is normal, and hemoglobin levels are normal. So she's for regular long-term follow-up up to 10 years. So granulosa cell tumors are sex-cord stromal tumors, as we all know. They're very rare. They are 2 to 5% of ovarian cancers. This is my third in Meru. I had one which I caught in 2022. It was, but it was at stage 4B due to involvement of jejunum. Then I had, this is the second one. And the third one I just got the results yesterday. So this is the third one. It's an indolent tumor, very indolent, it grows very slowly, and it's common in postmenopausal women. And we are seeing also a lot of perimenopausal women. So the clinical presentation is abdominal pain or swelling, menstrual disturbances due to the inhibin estrogen involvement, postmenopausal bleeding, and the recurrences occur in the pelvis, abdomen, bone, liver, lungs. So management strategy, if a patient is premenopausal, is just to do a USO. If it's postmenopausal, to do a standard surgical staging and surgery, that is TAH, BSO. And the issue of omentum, it's still very controversial in literature, but most people do TAH, BSO omentectomy. That is infracolic omentectomy. So prognosis by stage 1 has a very good prognosis of up to 95%, 5-year survival. Stage 2, 50 to 65%. Stage 4, 17 to 33%. So the need of adjuvant therapy. So for stage 1, it's very low risk, so only observation. For high risk or advanced, consider adjuvant chemotherapy. And for most chemo, they recommend the BEP regime, that is the bleomycin, etoposide, and cisplatin. Others can give cisplatin and carboplatin. For stage 1C, poorly differentiated, highly mitotic index or tumor rupture, consider adjuvant chemotherapy, but weigh from patient to patient. The granulosa cell tumors are usually very chemo-resistant, so you have to weigh the benefit of chemo vis-a-vis the side effects of chemo for the patient. But there's lack of robust trial data due to the rarity of this tumor. Clinical considerations is that evaluate benign ovarian cyst. If you see a cyst that looks benign, perimenopausal, menopausal woman, consider doing inhibin, especially those with postmenopausal bleeds, but actually be a granulosa cell tumor. And ensure optimal surgical debulking as much as possible, and long-term monitoring is essential. This is the case that I saw that I got the results actually last week on Friday. Another case that I did, and this one we did everything. We did, because it had tumor on the surface, we did TAH, BSO, omentectomy. We also did pelvic lymphadenectomy, and the results came back at stage 1C, adult granulosa cell tumor. I'm still weighing the management for the patient. We are thinking of really just follow-up, because we were able to remove the tumor in total. What was positive and made it stage C was tumor on the surface of the ovary, and the cytology for the ascites came back positive. So these are my references. Thank you very much. Any questions? Questions?
Thank you, Dr. for taking your time for surgery to come and present. Any questions? There's a Dr. Kyoko.
Thank you, Dr. Khadija, for that presentation. One question. For these patients who have, we can call it either menopausal or perimenopausal bleeding with a pelvic mass, should probably endometrial sampling be part of the workup for that patient even before surgery, considering if we are thinking about, the differentials and granulosa cell being one of the differentials, there could be some risk of having, some endometrial carcinoma related to high estrogen levels. So I don't know if that was part of the workup, just as a point of learning.
Thank you, Daniel, for that question. For this patient, the endometrial thickness was quite thin. Actually, I think it was 3.6 millimeters. So there was really no indication for endometrial biopsy for her. But yes, I do a lot of my pills in my practice, even before we go in for ovarian mass excisions. But for her, there was really no indication for endometrial sampling. Endometrium was very thin and was not taking color on Doppler. So there was really no risk for her, no need for her. Any additions, Dr. Odongo?
I think women who are in postmenopause or postmenopausal period and they have this abnormal uterine bleeding should undergo an endometrial assessment, because it will guide the kind of surgery we will do. I agree with Dr. Kioko. It's good to see you, Daniel, that women with granulosa cell tumor but higher propensity to having endometrial cancer and endometrial hyperplasia.
Thank you, Doctor.
Thank you.
Any addition on the need for no surgery for this patient? No additional surgery, Dr. Odongo. It was a very controversial case.
Yeah, this is an indolent tumor. Sometimes you wonder what to do with the sex cord stromols, mainly because of their clinical behavior. In that if they recur, you can always go back. So the indications for treatment most of the time is above stage 2 and stage 2 granulosa cell tumors. But on the other hand, you know very well, even if you give BEP, the response rate is around 40 to 50%. So you wonder whether you should really treat them or not.
I'm wondering, I think I'm old-fashioned. I've had her talk about estrogen level or inhibin is more superior.
For follow-up? Yeah, most of these issues is a resource issue. You can do as much as possible. Like if you suspect a woman has sex cord stromal, actually inhibin is more recommended. And to be specific, it's inhibin B.
Yes.
Yeah, inhibin B. Of course, you have got two isomers, inhibin A and B. If you have resources to do both, you can do both, but inhibin B. And the cost is around 16,000, 17,000. So you can imagine how many of our women can afford inhibin.
Thank you. Thank you, Daktari, for that good presentation. I'm just wondering, why didn't you do the BSO? You ended up by just doing one side. Maybe I missed the point. Because you had to you needed to talk to her.
Yeah.
This is whether you can go back in, and which she declined.
Yeah. That's a very good question, and that's actually why I did this presentation. I think we are always in a rush, generally, as generalists, to always, if somebody is above the age of 50, to remove both ovaries, even when there's no indication, So that was a point of argument for this case, and that's why I actually involved so many mentors to know the way forward for her. I'm not always in a hurry to remove ovaries unless there's an indication, yeah? I know 50 looks like an old person, but 50 is not an old person, right? They still require the estrogen supply, especially if they're not in danger. So what if this was a benign cystadenoma? Would you still remove both ovaries for her because she's at the age of 50? Do you still do TAH-BSO in patients who have fibroids because they're at 50 and they have fibroids, and we remove the ovaries? I think the world is moving away from that. We're looking at also the quality of women's life afterwards. Yeah. But it's a question that I asked myself also. But supposing it was a benign cystadenoma, would I have been justified to remove both ovaries? That was the dilemma in this question, in this patient, so to speak.
Yes.
I hope I've answered you. You should not be in a rush to remove ovaries just because somebody is at 49, 50.
Yeah.
Same thing with the leiomyosarcoma. I have done a leiomyosarcoma in Meru. I did not touch her ovaries because there is no indication for removing ovaries in a leiomyosarcoma. But if somebody will get excited with the surgery and see it's very ugly and remove both ovaries. But what have you done about the quality of that patient's life? Is there any benefit, oncologically speaking, to her? None.
We have an expert in the house, so I think we can answer those questions as we close.
That's a very good question. When do we do TAH and BSO for benign lesions? When you're investigating a woman with an adnexal mass, we always have what we call the risk of malignancy. index, especially if it's epithelial, whereby these perimenopausal women, if the RMI is more than 200, then the risk, the issue of preserving the ovaries does not arise, because it is part of staging and therapy also. But when you have a benign condition, or before I spoke about benign, even some malignant conditions like leiomyosarcoma, removing the ovaries does not confer any survival advantage. In fact, they end up being menopausal for a disease that you'd have just done TAH alone. So really, I would call it more of a judgment call when it comes to removing ovaries in the perimenopausal woman, from what I've given. Yeah, no, RMI is mainly for epithelial tumors. And I think we all know what RMI is, risk of malignancy index, whereby it's a product of CA125 ultrasound findings and menopausal status. And if you have RMI of more than 200, then you don't have to preserve those ovaries, because you're most likely dealing with a malignant disease and most likely an epithelial. But anything else, I would call it a judgment call.
Thank you, Dr. Thank you so much. I don't know if it was audible when I was answering that question, or I was already muted. So thank you for that. These were my thoughts.
Okay, thank you.
Thank you, Dr. Khadija. I did not introduce Dr. Elly Odongo, our next presenter. Dr. Elly Odongo is the current chair at the Department of Obstetrics and Gynecology at Kenyatta University. He's a gynecologist with over 25 years of experience and a senior lecturer. So he's going to be presenting on surgical management of cervical cancer. Karibu, Dr.
Thank you very much. Most of the meetings I go to, I find the podiums are very low for me. So many times I have to flex at the hip joint to reach the microphone. However much I try to straighten it. I hope I'm audible. I'm going to be speaking about surgical management of cervical cancer. We all know this slide. It is the second most common cancer, but in terms of mortality, is the highest. But for purposes of this discussion, it's good to understand that there are many variants of squamous of cancer of the cervix, and the commonest is still squamous cell carcinoma, with several variants, as you can see, papillary squamous cell transition. I put this because it also guides the kind of surgery that one will do once you understand the histopathology. The verrucous cancer, which really does not metastasize, the Wati type, and then you have got the lymphoepithelial type. Then you come to adenocarcinomas, which have several variants also. And there are others, including sarcomas of the uterus, neuroendocrine tumors, which tend to have a very aggressive kind of path, however small they are. And then the others that I've listed there. In order to understand the surgical interventions, it's good to appreciate the stages. And you can see we have this is figure 2018 staging, which has now incorporated the size of tumor, which has been now divided into three. That's 1B1, 1B2, and 1B3. And if you go to stage 3, we have incorporated radiological imaging to help in staging and to determine whether one is too fit for surgery or not. This has a direct bearing on lymph node involvement. The stage has direct relationship with the lymph node involvement. For example, stage 1A2, the risk of lymph node involvement is less than 5%. But as the tumors become bigger, the risk of nodal involvement gets higher. And this also guides the decisions that we make surgically and what of surgery to do. And these are the other factors of lymph node involvement, including how deep has the tumor gone into the stroma. If it is the inner third, is 5%, and the deeper it is, the more the nodal involvement. Parametrial involvement is a major risk factor for nodal involvement. So if you see an imaging that there's parametrial involvement, that already informs you that most likely 43% of the time the nodes are involved and you may avoid surgery in such situations. And histological grade, LVSI, and tumor size. The bigger the tumor, the more the nodal involvement. And that is why now we are moving away from surgery for very large tumors in that they end up with multi-modality treatment. Having said that, then we go to the specifics. In early stage cervical cancer, which is usually what we call the microinvasive disease, this is stage 1A1. It means less than 3 millimeter of invasion. These patients can actually just undergo a conization, a simple conization is sufficient for them, or a trachelectomy, which is rarely needed, or even a hysterectomy, which is really needed for this patient stage 1A1 disease. But remember, the cut is usually lymphovascular space invasion, because you can have a stage 1A1 with no LVSI, then a simple surgery will be sufficient. But once you start having lymphovascular space invasion, then you know that you're moving towards needing more aggressive surgery. So this is a summary of what we are going to talk about. And I've already mentioned stage 1A1 about conization. But when you move stage 1A2 to 1B1, you have three main options. Either you're going to do conization, whether you're going to do trachelectomy, and whether you're going to do hysterectomy. And we are now getting to the adopting some studies that have been done elsewhere. This includes the SHAPE trial, the CONSERVE trial, and the GOG 278, which has shown that over time, that when there is no parametric involvement, actually we should not be subjecting these women to very aggressive surgery, more so if there is no parametric involvement. So I've mentioned this, that cone biopsy as part of treatment. This has been part of the studies that have been done, especially the CONSERVE, the CONSERVE trial, which looked at conservative surgery for low risk early stage cervical cancer. And remember, low risk, we said stage 1A1, less than 3 millimeter of invasion, and no lymphovascular space invasion. And that's how you perform cervical conization, whereby you put hemostatic sutures at 3 and 9 o'clock, and then you grasp the cervix and use a number 11 blade to perform the conization and remove a very nice cone with a good margin. Now, we're having quite a number of women who have cervical cancer, and they are young, and they want to preserve fertility. And these are the women we are offering a trachelectomy. And there is a criteria for these women for one to qualify for trachelectomy. And this includes the stage itself, I've already mentioned, stage 1A1, 1A2, with LVSI. Remember when I said without LVSI, you can do a cone biopsy. But with LVSI, then you need a little bit more radical surgery. They have to have had confirmed cervical cancer. They have a desire for future fertility. They have not, that means they have no previous history of infertility. The age is a factor because of the pregnancy rates, which we are going to see later, what happens when one has undergone a trachelectomy. And there should be no evidence of nodal metastasis, either pelvic lymph nodes or para-aortic. And they should be surgical candidates because some patients are not good surgical candidates based on their ECOG performance status. And if they've undergone conization before, usually you wait for 4 to 6 weeks before you proceed with the trachelectomy. So I'll skip that, and because the reason why they undergo trachelectomy anyway is so that you can preserve fertility. And we can see the percentages that fertility has been described in close to 25 to 30% of these patients who undergo trachelectomy, and the vaginal delivery rate is pretty high, including deliveries born at term, close to half of them, but 25% of them have a preterm delivery for reasons we all know of. Once you trachelectomy, there is compromise at the lower uterine segment. Now, this is what we have been grappling with, whether we should change our practice. Is simple hysterectomy enough for early cervical cancer? And there are 3 trials that have answered this question. One is the CONSERVE trial and the SHAPE trial. And we've looked at the trends, more so that these patients with early stage cervical cancer, less than 2% have actually parametrial involvement. And once you do radical hysterectomy, they have a lot of dysfunctions, including sexual functions, urinary disturbance, amongst other quality of life issues. So we are now coming to a conclusion that actually simple hysterectomy with pelvic lymphadenectomy is sufficient for patients with early stage cervical cancer. So it's about patient selection. On this, you may want to read more. You can look at the SHAPE trial and the GOG 278. But once you go to bigger tumors, 1B2 and 2A1, it means that this may not be amenable to simple hysterectomy. These are the kind of patients you offer radical hysterectomy. And radical hysterectomy, many times I see, is called Watten's hysterectomy, which Watten's is usually a misnomer, because Watten's initially did not do lymph node dissection. People did lymph node dissection are people like Thomas Lonescu. That's why nowadays we call it radical hysterectomy, when we started calling it Watten's. Why do we offer surgery? Because surgery has several advantages over radiation. One, you may remove some radio-resistant tumors by offering them surgery. You can preserve ovarian function, mainly because once you radiate, then even if you transpose the ovaries, there is almost always a scatter radiation when you're radiating the pelvis and sterilizes the women. So what kind of hysterectomies do we do? And there they are in our practice at Moi and where I was before. We were doing class 2-3 hysterectomies, whereby you get the uterine artery from origin and the ligaments from origin. You get a good curve of the vagina. When you go to class 4 and 5, you'll be sacrificing the superior vesical artery and even the distal ureter, which really has a lot of mobilities. Now, after you do the hysterectomy, occasionally not all patients are cured by surgery. And so we look at 2 criteria. We have got the Sedley's criteria and the Peters criteria. So just to summarize, the Sedley's criteria are about the tumor size and depth of stromal invasion and presence of LVSI. If you have got 2 factors, then you know this patient will need adjuvant treatment. And Peters criteria are actually high risk. After you do the surgery and you find that the margins are positive, the nodes are positive, the parametria are involved, then this patient should undergo adjuvant concurrent chemoradiation. So just to look at the survival rates, you can see stage 1A1 has very good survival rates. Stage 1A, 95%, 1B, 80%. 363, 263, 336, and stage 4 actually is between 15 to 20% survival rate. Thank you very much, and I'll take a few questions.
Thank you, Dr. Odongo. Any questions?
We are in Meru, so I'm going to report ourselves. Because of lack of accessibility to radiotherapy, we are the oncologists around. Usually, after we make the diagnosis, usually they proceed with the chemotherapy. I'm not sure most are able to follow up with radiotherapy, but some of the oncologists go ahead and refer the patients back, especially when the bulk of the disease has been removed or cured by the chemotherapy. I don't know what is your take in terms of that kind of approach. Of course, we know that the best is the concurrent chemoradiation, which may not be very accessible in our setup.
Yeah, we have published studies of, we call it reduction of cytoreduction of the tumor. We used to use cisplatin, but then we found that you reduce the tumor, but the outcomes are as they are worse off in terms of after surgery, they still have positive nodes and all that. And now that you asked that question, we have just discussed one of the key practice-changing trials called the Interlace trial. The Interlace trial looked at patients with large tumors. They put them on 6 cycles of carboplatin and carboplatin paclitaxel. But after that, they did not undergo surgery. Then they proceeded with concurrent chemoradiation. And actually, the outcome was better for patients who underwent carbotaxol for 6 cycles, then proceeded with concurrent chemoradiation, as opposed to those who underwent chemoradiation upfront for these very large tumors. Yes, they still have to go for radio. We can look at archives. I know, Daniel, the studies we did, because women came with very large tumors. So you are reducing it and then operate. Then you realize even if you do surgery, the nodes will still be positive. The margins will still be kind of very close. They still need to undergo CCRT. So why don't you subject them to one modality of treatment?
Yes, Dr. Odongo, thanks so much for that illuminating presentation. I have a patient who was stage 3 CSR, but underwent that radical hysterectomy. And the justification was the person who did it, one of the gynecs, is that the lesser you reduce the tumor, the better for the response to chemo and radiotherapy. I couldn't understand that logic because from those days when we were in school, surgery is limited up to stage 2A. But now this one is going beyond. So I don't know whether you have come across such a kind of argument about surgery at advanced stage.
No, that is not the standard of care. Once you have got lymph node involvement, actually abandon surgery. Sometimes you go in and thinking it's an early stage disease, but once you start, you realize that the nodes are palpable because we have no way of doing frozen section currently. In other parts of the world, they start with the lymph nodes. By the time you are deciding to proceed, you already have the results that the lymph nodes are free of tumor. The reason why we have got FIGO 2018 staging and including imaging is that once you see the nodes are involved, do not operate on that patient. They're better off with concurrent chemoradiation.
Thank you, Dr. for the presentation. My name is Gaboga. I'm just a very junior obstetrician. Now, my question is, when you're considering to offer the fertility sparing surgeries, do you also consider this histological subtypes? Do you still offer it to the aggressive type, regardless of whether there is no lymphovascular space invasion?
Yeah, that's a very good question. And that's why I brought about the histological subtypes. In women with neuroendocrine tumors, especially the small cell type, much as you're offering them fertility sparing, you know very well that the prognosis is not good. From our data, even stage 1A1 small cell cancers, we've had some coming back with brain metastasis. So, but when you're counseling them, they should be aware that the fertility sparing may not necessarily be offering them a good prognosis. So it's a kind of a discussion, but also considering what you call the patient autonomy. You offer them that, but then you also know that if they decide to proceed with it, well and good. But from my advice for these high-risk types, neuroendocrine types, we need to be a little bit more careful when talking regarding fertility sparing. And that's why I made this presentation, because we have a lot of cervical cancer, which may not be managed by a gynecological oncologist. And remember, one of the slides was, is there a role for simple hysterectomy for low risk cervical cancer? And from SHAPE trial and from CONSERVE trial, there is a role for simple hysterectomy for that. But then you must also do pelvic lymphadenectomy. Yeah. So I don't know how to answer that question. But for a 1A1, really, conization. Yeah. Yeah.
Oh, thank you, Doctor. Thank you, Doctor.
Yeah.
I learned not to stand next to him a long time ago. There's a picture from Jerry. Thank you so much for that wonderful presentation.